So I actually, in discussion with James, it's not going to be only on MR angiography, it's about how we image the aorta, and there's some other aspects in there that are very, very important depending on the different aspects, what diseases we're actually looking into. So these are my disclosures regarding to this topic and this talk. And the agenda is going to focus on three aspects. It's going to be something, what MR approaches do we have in terms of imaging of the aorta, different aspects, lumen, wall, whatever. Some anatomical aspects in terms of how we do the quantification, and some what are the informations that we actually need to give the clinicians in terms of the therapy approaches. And this is not necessarily the order of the percentages of what people are coming to us in terms of imaging questions, but a very typical aspect is something like there's an echocardiography done, we see some dilatation of the aortic root, please assess further. May have only been a screening echo, might have been a bad echo, but then those patients come into CT or MR, most often MR, because young patients, they may have some valve disease as well, and that's all you get in terms of the clinical information, and 0.2 further assess, especially the thoracic aorta, with a focus on the ascending aorta as well. Then there's a growing group of what people now call genetic aortopathies, which is Marfan's disease, Loeys-Dietz disease, Ehlers-Danlos, or all these familiar thoracic aneurysmic syndromes, and it's a whole bunch of different genetic bases, and they may have different expressions. And of course, in this patient population, screening and follow-up is a very important aspect, and we're talking often about young patients or potential patients that are exposed to those diseases. MR is the #1 modality of choice. Then we have inflammatory diseases like Takayasu's, giant cell arteritis, congenital heart disease in terms of arches, vascular rings, and which is potentially the largest group, not necessarily at our center, is the common atherosclerotic disease in terms of aneurysm dissections and different aspects. But the questions that are most often coming up is essentially three different aspects. Is there something like an aneurysm, is a dissection, or is there any stenosis? When you think about coarctation, we're focusing on the stenosis specifically. So in terms of the imaging protocol that we typically follow, in case it's not a question where we actually know it's not about the ascending aorta, it's a fairly easy imaging protocol. We have some basic anatomical coverage, mainly done with a T2-weighted haste imaging across the chest. Occasionally we may do some sagittal fast spin echo techniques when we're talking about aortitis or Takayasu's. Then of course we typically do 3D MRAs, which is most commonly dynamic and static contrast enhanced MR angiography, techniques we heard about this morning. And there's the occasional patient who doesn't want to get contrast or has contraindications to contrast applications, and then we go for 3D non-contrast enhanced MR angiography. So I'm going to show you some examples. This is a case I'm going to show you actually the non-contrast and the contrast enhanced in the same patient for specific reasons. We did both imaging here, and you can nicely see the dissection membrane, this type 2 dissection here from the arch, or just distal to the arch vessels, well into the abdomen, very nice homogeneous contrast. You can see windows, you have a high spatial resolution. The only thing you don't have there is any information about dynamics of contrast or the filling pattern of the contrast into those different lumens of the dissection. This is the same patient as I mentioned just before. This is two different phases of the angiography. You see on the left side the earlier phase, we see the true lumen nicely opacifying, and then in the later phase you also see a more homogeneous contrast in the true and also the false lumen. And you see at the bottom how we actually perform our angios. We use a diluted approach in terms of covering of the case space. The acquisition time at the moment is around 20 seconds, and we're getting about a 0.9 by 0.9 by 1 millimeter spatial resolution. And then what we actually do before, so we actually use the dynamic MR angiography as our timing bolus as well. So we thought not going just for bolus triggering, we go for dynamic MR angio, which gives you some information. Sometimes in case a patient cannot hold the breath, it's actually sometimes the only diagnostic image quality series where you can pick a certain contrast phase. And then we get the dynamic information, use this also the test bolus, and in this case you also see the difference in the filling of the different lumens, which gives you some information, not necessarily flow information, but some information about the enhancement of the different lumens. So moving on, just showing you something that may happen, and we have seen the nice talk about acceleration in imaging these mornings. There's major efforts going on to further improve dynamic imaging and also static compressed sensing MR angiography. This actually just shows you identical raw data on the left versus the right. Once you use iterative reconstruction, you get a substantially better temporal footprint, which may improve, number one, signal to noise, and especially in the chest, you see the differential and the benefit in terms of the small vasculature. This is done at 3 Tesla, where we sometimes have issues, especially with the polyvasculature, and also sometimes you see now with the new approaches, the enhancement in the tissue. This is some advances in terms of imaging, but doesn't really necessarily change at the moment the way we acquire data. Then the only difference in case we have patients where we look into diseases that affect the ascending aorta essentially is adding on EKG-gated sequences of the aortic root, potentially the outflow tract. And that's the only difference actually we do. Otherwise, the rest is pretty much identical as compared to the non-ascending aortic diseases here. And let's show you 2 different examples here where we have a enlarged but tricuspid aortic root. We see normal aortic valve, but the enlarged root. And on the right-hand side here, you see a bicuspid aortic valve with a fusion with a raphe between the right and the left cusp. As we heard this morning from Mike Hope, this has impacts on the flow pattern, the flow direction into the ascending aorta, and has some impact in terms of development of potential aneurysms. So these are important aspects. Requires EKG gating. Is not as easy in terms of setup as compared to the contrast-enhanced MR angiography. And another case here, we are happy to have one of the world's most famous surgeons in our hospital, Tyrone David, who invented the David procedure. That's why we actually have a lot of Marfan patients coming up in our hospital. This is a young patient you see here prior to surgery and after David procedure here with a replacement, but the valve has not been removed. David procedure is a valve maintaining surgery where the ascending aorta is replaced, and those patients are coming up because they have certain diseases like Marfan's for annual follow-up. One aspect you can do as well, which is something we actually perform in aortitis, we add these T1 weight images, which is an anatomical information to see thickening of the wall, whether it has an impact. Once you talk to rheumatologists these days, they are predominantly interested about development of new stenosis, not necessarily about contrast agent uptake in the wall. They don't really care. They want to see the stenosis. That's all it matters. On the center slide, you see the same technique applied in a patient with a dissecting aneurysm of the descending thoracic aorta, and just shows you how complex the contrast mechanism may actually be. This is the sagittal, this is the axial image. I'm just going to overlay the one with the contrast-enhanced MR angiography, and you see this part here is still slow-flowing blood, while the rest is different signal intensities in a complex thrombus of the aortic wall. We not necessarily use that for a lot of information. This is something that may be of interest in case you have a patient coming out for, let's say, acute chest pain, acute aortic diseases, when it's about penetrating aortic ulcers, potential intramural hematomas, a population we rarely see in MR. In our hospital, those patients are predominantly going into CT and CT follow-ups as well. It's just the overview of the techniques we actually use for imaging of the aorta. When it comes to the assessment of the aorta, we have to consider that we have certain different parts. The aorta is named one vessel from the root to the bifurcation, but essentially we have multiple different parts, which is essentially the aortic root, where we need to have EKG gating because of a lot of motion going on there. And then we have the ascending aorta, which goes just to the brachiocephalic arteries. We have the arch vessels. Then we have the descending thoracic aorta, and then we go into the abdominal aorta. Everything distal to the sinotubular junction, which is the connection between the sinus portion of the aorta to the tubular portion, everything distal to that can be pretty much imaged without ECG gating, without getting a lot of imaging artifacts, but below this STJ, we need to apply EKG gating to get reasonable good imaging. In terms of measurements as recommended by the different societies, we typically go ahead with a measurement of the aortic root in case we go for imaging for the aortic root, sinotubular junction, mid-thoracic aorta, mid-ascending aorta, then just proximal to the brachiocephalic artery, at the isthmus, mid-descending thoracic aorta, at the diaphragm, and then suprarenal and infrarenal aorta measurements. That's a standard approach that's typically recommended. And of course, we have a pathology. You also need to give measurement in the area of pathology in case of an aneurysm, the maximum diameter. Coming to those images, and we have seen nice data about the different ways you can present data. This is something that's very nicely shown to patients and also appreciated by the surgeons because they get an overview of what's going on there. In terms of reporting, those images are not necessarily very, very helpful because you can't do really good measurements of those data sets. But using the same data sets, you can certainly do a couple of different approaches. This is a case with a very large ascending aortic aneurysm going into the aortic arch. And the standard approach recommended these days essentially is measure the aorta along its center line, and then due to the measure, or reconstruct along the center line and perform measurements perpendicular to have a nice cross-section of the vessel. We have to keep in mind it's not necessarily the one-time measurements that makes an impact on the patient. It's those patients that keep coming back for an annual follow-up, and you need to be good enough in terms of reproducibility to see a change going on and not having the measurements going back and forth, changing all the time, although there's no real change in the diameter. And clinicians are heavily depending on those measurements in terms of their therapy decisions, especially in young patients. Does a patient need to undergo surgery in case of Marfan's disease, or is it still good to follow up? That's very, very important these days. But in case you go for those cross-sectional measurements, keep in mind, and David Salomon mentioned this morning, it's sometimes very, very tricky to get the accurate measurement because the windowing is so important. In terms of studies, people have proposed approaches like 80% of full width at half maximum, or half full width at half maximum, to really get reproducible measurements in terms of stenosis especially and the luminal diameter, something that's hard to do in clinical routine, but the center line approach is also very, very important. In this case, it's actually a little bit funny. You see the ascending aorta, a large aneurysm. Once you look here, you measure this aortic lumen. But once you window it slightly differently, you see this is only the lumen. This is not the aorta. The aorta is the lumen plus the thrombus. And obviously, we need to measure especially the entire size because this drives the outcome of the patient. Another case here where we're not looking into aneurysm, we're looking into stenosis. And in case you see that here, you see a nice coarctation here, typical location. Those stenosis are typically very, very short. It's just like a waist here, which is actually very, very hard to measure in case you do those reconstructions. In case you see those values here, it's actually very, very hard to calculate a diameter stenosis because it's not a round-shaped structure anymore. In case it would be round-shaped like in the normal distal diameter, it would be easy to measure here as well, but it would be kind of oval-shaped here. That's why it's actually much better to go for area measurement. You can get the exact degree of stenosis. You will see also flow measurements in terms of Foley flow across those aspects. The only thing to keep in mind is that sometimes the calculated gradient might not be entirely accurate because of the flow over the collateral flow here. So it's very, very important to do those measurements here as well. About the aortic root, there's different ways to measure the aortic root. And we're kind of stuck in between what the clinicians are used to because they're using echo most of the time and what we know is the best way to measure in CT and MR. So there's two different ways. You can measure cusp to cusp, which is the largest diameter in general. Something is typically followed in echo. But we can also measure cusp to commissure, which is much easier. See the cusp to cusp, the red ones, where it's kind of variable, where you actually put your points. In case you go for the cusp to commissure measurements, you actually have the commissure and the opposite deep end of the cusp. And this has been shown to be a better way, or not saying a better way, a more reproducible way to measure diameters in this area. However, the limitations here is, I'm just going to skip this aortic valve stuff here because I see Matthias already coming on my side. This is the lack, and actually I think James was hoping to get more insight. We're lacking normal data. There's tons of different publications about different sizing and different things, but every single table is different. In case you compare those different things, this is about normal weight, this is different age groups, we're not getting to the same value. So we don't really have a clear cutoff. The root is still the best in terms of having cutoffs, but in terms of ascending aorta, there's no real cutoff. What is an aneurysm? What is non-aneurysm? What is dilatation? And there's no data that's based on CT or MR angiography data. Most data is based on cine imaging, which is systolic and diastolic, or phase contrast. There's a huge lack of data out there. And in terms of recommendations, root is actually relatively easy. There's clear data, I can hear you. In terms of thoracic aorta, we just follow a simple rule these days. Up to 4 is normal for the ascending aorta, above 4 is dilate, and above 5 we call it an aneurysm. Because of the therapy decisions in terms of clinicians, it's actually depending on the disease you have, and sometimes the cutoff in terms of going to surgery is much different from what we actually think it is. A patient with Marfan's goes to surgery later on than a patient with Loeys-Dietz syndrome because of the rupture risk and dissection risk is much higher. I'm going to skip this one as well. I'm just going to sum up the end. Aortic MRA, or better to say aortic MR imaging, has an increasingly important role into screening and follow-up and surveillance of those young patients. And we all know we have no radiation. That's why it's the modality of choice to go into those patient populations. What we need to have, we have to have reliable ways to measure and always get the same result in case of a change. Then this is the only way to really indicate a change and give this information to the clinician. And just want to mention this, have a common knowledge. Sometimes we see fellows coming back from fellowships, they're talking a different language from a different center, which is not, the clinician is not used to your own center. So they have to adapt a little bit in this way as well. And as I mentioned before, we have this lack of normal data for normal reference values. There's more in the abdominal aorta, a real lack in the thoracic aorta. Thank you for your attention.